All right, we're going to start off with another one of your favorite subjects, the endocrine system, okay? Now, the endocrine system is one of those systems that students tend to get very confused in school. And the reason for that is if you ever did try to read the endocrine chapter, you notice that they started using lots of different words to describe the same thing. Like you'll see when we get to the glucocorticoid section, steroids, 1 minute they'll say steroid, then they'll say hypercortisolism, then they'll say increased levels of ACTH, and then they'll say Cushing syndrome, and it all starts running together in your mind. So what I'm going to do here is we're going to separate out the endocrine system, okay? So you won't get it all confused anymore. Now, we started getting endocrine yesterday when I mentioned two chemicals, aldosterone and ADH. Do y'all remember that? That was a long time ago, I know, all right? But let's talk about aldosterone for a second because this is very much a part of the endocrine system. All right, so aldosterone. The normal action of aldosterone is what? What did I say it's going to make you do? Retain what? Sodium in water. And we said yesterday that if you want to get aldosterone questions right, you've got to say sodium in water, right? Now, we also said with chemicals, you can either develop too much of that chemical in the body or you may not have enough. So, let's say we have a problem where we're making way too much aldosterone. If I'm making way too much aldosterone, I'm going to retain way too much what? Sodium in water. Where am I retaining that sodium in water? Vascular space, so therefore I'm going to go into a fluid volume excess, overload, okay? Now, what's the name of the diseases that we talked about yesterday where you're making way too much aldosterone? Cons, Cushing's and cons. And we also emphasized that Cushing's is when you had too many of all of your steroids, not just aldosterone, okay? Now, the other name for cons is what? Hyperaldosteronism, and we all agreed that we would have gotten that on the test, right? Right, okay. Now, could I have a situation in my body where I'm not making enough aldosterone? Yes. Tell the person sitting next to you how the vascular space is going to be affected if we do not have enough aldosterone. Tell me. Are you going to retain sodium in water? No, you're going to lose sodium in water. So the patient's going to go into a fluid volume deficit, okay? Now tell me something. What's the name of that disease? Addison's disease, all right? And one way that people like to remember Addison's disease is, and I can remember my teacher saying this in school, you need to add steroids. You don't have enough steroids, so you need to add steroids, Addison's disease. Now, the other chemical that we talked about yesterday was ADH, anti-diuretic hormone. Normally, does ADH make you retain or diurese? Retain, because it's anti-diuretic. Now, what's the key words you've got to think of when you think of ADH? Water, water, water. Are we going to say sodium in water? No, because we don't want to miss test questions now, do we? Okay? Now, you're just retaining water, and just like any other chemical, you can have too much ADH or not enough. So let's talk about too much. My body is making way too much ADH, therefore I'm going to retain too much what? Water in my vascular space, so I go into a fluid volume excess. Normally, when people are in a fluid volume excess because they've drank a lot of water or gotten too much IV fluid, whatever, normally what will their urine output do? Increase to help them do what? Excrete the excess. Is that happening with this disease? No. Why is the urine output, tell the person sitting next to you, why the urine output is decreasing in SIADH? Because we're making too much ADH, which is forcing me to hold on to all of my water, which makes my fluid volume excess problem even worse, okay? Now also, we said yesterday that the blood and the urine look alike. They mirror each other in normal conditions, right? Well, in SIADH, when I'm retaining all this water, my blood's going to be very dilute, but my urine, since my output is down, is going to be very concentrated. So they're not looking alike. That's not normal. And I told you yesterday that dilute makes numbers go down, and concentrated makes numbers go Up. And what are the two numbers I'm talking about? Specific gravity and the sodium. No other electrolyte cares about the water deal, right? Okay. Now, the other one we talked about was diabetes insipidus. That's not enough ADH. And I told you to circle the D in DI, and anytime you saw diabetes insipidus to think what word? Diuresis. Now, tell the person sitting next to you why the patient is diuresing so. Because they don't have enough what? ADH. So they're losing all of their water. So they're going into a fluid volume deficit. Could they go into shock? Okay, normally when people are in shock, any other kind of shock, what's going to happen to urine output? It decreases to help them do what? Hold on. Is that happening in diabetes insipidus? No. What's happening here? They're in shock, but still putting out what? Large amounts of dilute urine. Could that kill them? Absolutely. So see, that's when we said the patient's going to have to be given some kind of exogenous drug ADH to stop the problem, right? Okay. And once again, tell the person sitting next to you about the urine in the blood. One's concentrated, one's dilute. Tell your friend which one's which. Urine? Okay. And then the urine's going to be dilute, okay? Blood? Concentrated. Now tell me one more thing. Where does ADH live? Pituitary. So yesterday I said that people just don't appear one day at the ER saying, oh, my ADH is messed up. I told you that it was always secondary to other things. ADH problems were sneaky, like you got a head injury over here. Or you've got somebody with sinus surgery, or the dreaded transsphenoidal hypophysectomy, right? Okay. So anytime we see a head thing, are we going to worry about ADH problem? Yeah, especially if in a test question they give you a head thing, anything close to the pituitary, and they give you urine output in the scenario 2, you cannot forget about the potential ADH problem. The problem is you never know which one people are getting. Some people get SI and some people get DI. All right, so there's your first two endocrine things that we talked about. I never, ever, ever want you to mix ADH problems with aldosterone problems, okay? That's two separate things altogether. One's made right here and one's made right here, okay? Your adrenal glands. All right, now then, let's look at the endocrine system on page 30. Thyroid problems. The thyroid produces 3 hormones, T3, T4, calcitonin. Circle T3 and T4. Those are the ones I'm most worried about right now. We talked about calcitonin yesterday. We yesterday said that calcitonin does what to serum calcium? Decreases serum calcium by driving it back into the bones. Okay, so that's all we're going to say about that. That's enough about calcitonin. Now, you need what to make these hormones? Iodine. And this is dietary iodine. I emphasize that this is dietary iodine because there's 2 different kinds of iodine in the world. The kind you eat, and we all eat plenty of iodized salt, don't we? Okay, and then there's also drug iodine. And there's drug iodine and dietary iodine have 2 totally different actions altogether, okay? So don't get them confused with each other. The kind you eat helps you make more hormones, all right? Now, thyroid hormones give us what? Energy. So if you understand that sentence, you already understand the difference between hyperthyroidism and hypo. Because with one, you've got too much energy, and the other, you don't have enough. All right. Hyperthyroidism. Too much energy, also known as Graves' disease. This patient is very nervous. If you're full of energy, what's going to happen to your weight? Up or down? It's down. They're sweaty. They're hot. They get exophthalmos. What's that? That's right. Bulging eyes. That is an irreversible effect, y'all. You never want people to get to that point because once they've got it, they've got it. And they really don't know why it happens, but they do know this. The patient starts getting abnormal fluid accumulation behind the eye itself, which pushes the eye forward. The fluid is not in the socket. That would be glaucoma, wouldn't it? This is fluid behind the eye, pushing the eye outwardly. What's going to happen to your attention span? Increase or decrease? Decrease. Appetite is going up. This person's eating more but losing weight. Wouldn't that be fun for a month? Yes. Irritable, of course, because they're so nervous. GI tract, is it going to be fast or slow? If you had to pick, you would have to say fast. Now, the reason I say that is in textbooks, you'll read, like with hyperthyroidism, they'll say some patients have constipation, some have diarrhea. When you're going to take a test like NCLEX, you've got to learn what's the most common thing in patients, and then realize that everybody's different out there in the real world, okay? Blood pressure in hyperthyroidism is going to go up. Well, anytime you've got high blood pressure, now we have to worry about heart troubles, don't we? Yeah, because when you have high blood pressure, what just happened to the workload on the heart? Increased workload on the heart. Thyroid itself is going to get bigger. We call that a goiter, don't we? Now, here's the deal, y'all. Anytime you have an organ in your body that's working overtime, what happens to the size of it? It hypertrophies, doesn't it? Like if your heart's working too hard, well, the thyroid is working really hard trying to make more hormones, so naturally it gets larger, okay? Now, don't get me wrong. You can have a goiter with hypothyroidism too. Because with hypothyroidism, your poor old thyroid's working, trying to make more hormones, but is it making any? No, but see, whether it's hyper or hypo, the thyroid's still working hard, so it still gets bigger. Okay. If you drew a serum T4 level on this patient, would it be increased or decreased? Increased. That's just another way of asking you about those hormones. And diagnosis, well, one way they diagnose is besides looking at your symptoms and your blood work, they're going to do a thyroid scan. And they give you something radioactive and injected, and that radioactive stuff has got iodine hooked to it. Well, if you have hyperthyroidism, if any iodine gets in your blood, where's it going to want to go? Thyroid. So they do a scan and they see a big glowing thyroid, basically, is what we're looking at. All right, let's look at our treatment here. We always think about drug therapy first here. Now, antithyroids like Propofol, PTU, Tapazole, it's been the same drug since I was in nursing school, okay? Stops the thyroid from making thyroid hormones, and we want this patient to become euthyroid, and you know that euthyroid means normal. Anytime you see the letters EU before a word, we know that means normal. And these medicines have to be tapered and discontinued, because if you do not taper and discontinue them, you're going to take the patient from hyper to hypo. Is that what we wanted? No, that would be a bad side effect, wouldn't it? That would be an adverse side effect. Hypothyroidism, I want normal thyroid function. Now, here's the drug iodine I was talking about. Iodine compounds like potassium iodide, Lugol solution, SSKI, they have a different action than dietary iodine. The action is they decrease vascularity. That's why they give these drugs pre-op to decrease bleeding. They're given pre-op to decrease bleeding. Pre-op to decrease bleeding. It says to give him milk, juice, use a straw. And anytime we have a drug where they're wanting us to use a straw, it must do what? Stain the teeth. Stain the teeth. Now, beta blockers are good for this person because beta blockers are going to decrease the heart rate and the blood pressure. But y'all, aren't there a lot of other cardiovascular agents out there in the world that will decrease heart rate and blood pressure? Yeah, there's a lot of them. So I wonder why they picked a beta blocker here. Anybody know? Because beta blockers decrease anxiety too. Beta blockers decrease anxiety too. And isn't that good for this person? Yeah, you got a real nervous person here. You know, you'll hear things like this. Maybe a friend of yours has to give a speech on Friday night, and they're so nervous about getting up in front of somebody and talking. Well, they go to the doctor, and the doctor gives them 10 Endoral, and they'll say, take this a little bit before your speech, about an hour before, and you'll just stay calm as you can be. Because the way that beta blockers work is they don't let you release epi and norepi. That's what you get a surge of when you get scared, right? If you're over here at Walmart parking lot 2 o'clock in the morning, okay, and you go and shop, and then you walk back out to your car, it's about 3:30 now, all right, and you get back out to your car, and there's a large man waiting for you there that you don't know. What are you going to get a surge of? Epi and norepi, which makes you able to do what? Pick up your buggy and run faster than you've ever run, right? Because he is not going to get your Walmart stuff. But y'all, what if I were on a beta blocker and I go walking out to my car with my buggy and I look up and he's there? What am I going to say? Hey, how are you doing? Right? Because am I going to get a surge of epi and norepi? No. Now I know what some of you are thinking. I'm going to get me some of that before I take my test. No, you're not. Because also look on your handout. Beta blockers can decrease myocardial contractility. Not everybody can handle that, okay? Because it can decrease your cardiac output. And when you decrease cardiac output, what could happen to your head perfusion? Decrease it. You do not want to mess with your head perfusion prior to taking your test. Now, do you? No. Some people get put on a beta blocker, y'all, just for their high blood pressure. And their blood pressure is controlled, and they just have a great blood pressure, but their cardiac output has dropped so much, they can barely drag around the house and go to work. Or what just happened to the quality of their life? Down on the beta blocker, but I got good blood pressure, right? They're not going to leave you on that drug because not everybody can handle a decrease in cardiac output. Also, look at my rule. Do not give beta blockers to asthmatics or diabetics. That's a rule. That's a big no-no. If you give a beta blocker to an asthmatic, it can actually bring on an asthmatic attack. Can bring on an asthmatic attack. Now, the diabetic. Now, let's listen to me for a second. Let's pretend I'm a diabetic. And I'm getting shaky and nervous and jittery and nauseated. My pulse is going up and I'm getting a headache. What are these signs and symptoms of? Hypoglycemia. If I am a diabetic, do I need to know it when I'm becoming hypoglycemic? Yeah, so I can hurry up and get me a snack, right? Drink a Coke or something. Because every time that blood sugar drops, I lose a few brain cells, you see. But if I'm on a beta blocker, can I get shaky and nervous and jittery? No, because I'm unable to release what? Epi and norepi. So see, diabetics should never take a beta blocker because they hide hypoglycemia, which can be very dangerous for a diabetic. Now then, radioactive iodine. One dose is usually all that's needed, and notice it's going to destroy thyroid cells, and the patient is going to become hypothyroid. That is expected. That's not a bad thing. That's what we expect to happen. Also, we have to follow radioactive precautions. Well, that makes sense to me since it's radioactive iodine, right? But the two things you got to remember here are these, okay? You stay away from babies for 24 hours. You stay away from babies for 24 hours, and you do not kiss anybody for 24 hours, unless it's somebody you want to radiate, and then you could kiss them, okay? Now, that's bad. That's mean. You see, y'all, yesterday we talked about a lot of radioactive precautions, like a private room and all that stuff. This is out of the system probably in 48 hours, all right? So it's not as big a deal as what we talked about yesterday, but those are two specific things you do have to consider. Now, on the next page, thyroid storm. Watch for thyroid storm. Thyroid storm, thyrotoxicosis, and thyrotoxic crisis are all the same thing. It's hyperthyroidism multiplied times 100. So is this an emergency? Yes. It's time to go to the ICU. I may be about to have a MI, a stroke, heart failure. It's very serious. Now, let me make something clear. Anybody who is hyperthyroid can go into a storm at any time. I do not have to have had radioactive iodine to go into a storm, but I'm talking about this under radioactive iodine on purpose. What did I tell you radioactive iodine was going to do to the thyroid? Destroy. Make you hypo, right? It's going to destroy. So when you destroy part of the thyroid, what happens to the hormone levels in the blood? They drop. This little piece of thyroid that's left is looking at the blood saying what? Where'd all the hormones go? So this little piece that's left thinks it better hurry up and do what? Make more. So this is what I want you to write down about this thyroid storm. This is why I'm talking about it under radioactive iodine. Could be a rebound effect post-radioactive iodine. Could be a rebound effect post-radioactive iodine. All right. Now surgery, thyroidectomy. May be partial, may be complete. This is just another form of treatment. Post-op, teach how to support the neck. Normally they'll have an incision here. They try to make the incision low enough because so your blouse would cover it up, okay, if you were worried about a scar showing or something like that. But remember, you've got to support the neck because do you want any tension on the suture line? No. So when they're sitting up in bed, they really need to do their fingers like this, behind their neck to pull up in bed or turn to support the neck because it's weakened right now. But another thing I always remember is this. Put all their personal stuff close to them, like their water, their phone, because if that phone rings in the room and they reach for it, what did they just do? Stretched. We don't want tension on the suture line. Positioning. We've had a surgery right here. Do you agree with all surgery there's always a little bit of edema? But since it's here, what am I worried about? Airway. So what shall we do to the head of the bed? Are we going to elevate it or lower it? Talk to me. If you're worried about edema, you elevate the head of the bed to decrease edema. Elevate the head of the bed to decrease edema. Many times, now y'all, let me say this. Positioning is one of the most important things you'll do as a nurse. You need to get into the habit. From the minute you see your patient returning to you from a procedure, whether it's a heart cath, this, whatever, you need to start thinking about what position am I going to put them in. That's a safety thing, isn't it? Because the doctor doesn't always order it, okay? All right, check for bleeding where? Behind the neck. That's where pooling can occur. And remember, blood doesn't have to come out where you can see it on the sheets. You need to look to see if it's accumulating in the tissue. All right? Nutrition pre and post-op is very important. I bet your teacher told you when you were studying about the surgical patient that patients always do better post-op if they're well nourished, right? Well, if you've had hyperthyroidism, you've been losing weight, you see. So they got to build them up. They need more calories, that sort of thing. Assess for recurrent laryngeal nerve damage. Well, what's the magic word here that I'm listening for post-op? It starts with an H. Hoarseness. That's what you're listening for post-op to see if they have recurrent laryngeal nerve damage. Now, why is that even important? Why do I care that you're hoarse? Because of the next sentence. Could lead to vocal cord paralysis, and if there is paralysis of both cords, airway obstruction will occur requiring immediate trach. You see, NCLEX is all about life or death situation, so that's why I'm always trying to pull out the life or death scenario here. That's why we care about it, okay? Now, we keep a trach set at the bedside for hypocalcemia, swelling, and there's the recurrent laryngeal nerve damage. Now, I'm going to come back to hypocalcemia in just 1 second, all right? Teach to report any complaint of pressure. I don't care if in a test question they just say your patient has a teeny tiny little bitty baby bit of pressure here. Are we worried? Yes, we are going to assume the worst and assume that we got an airway thing going on, right? All right. Now, assess for parathyroid removal. Y'all, we talked about PTH yesterday. How do you walk in the room and look at somebody and say, oh, I'm sorry, girl, they got your parathyroids. I can look at you and tell you don't have parathyroids anymore. I'm sorry. Now, tell your friend how you know somebody's parathyroids have been accidentally removed. Come on, talk. If you need to, you can go back to hypocalcemia page and fluids and electrolytes. Oh, you don't want to go back that far, do you? Okay, well, let me talk you through it. Okay, here's the deal. Parathyroids make what? They don't make calcium, they make PTH. And the normal action of PTH is to make your serum calcium go up by making you pull it from the bones and place it in the blood. It's a good thing we went over this, I can tell. Okay? So let's get this straight. The normal action of PTH is to make your serum calcium go up. Do we all agree? Okay. Now, with this surgery, a thyroidectomy, could the doctor accidentally remove a couple of your parathyroids? Yeah, because you got 4, all right? They accidentally removed, so you don't have as much PTH as you used to. So now, post-op, my serum calcium might start to go down. That's what I'm worried about post-op, hypocalcemia. That could be very life-threatening because, y'all, calcium acts like a what? Sedative. If you don't have sedative, what are my muscles going to be like? Rigid and tight. Could I get into an airway issue? Could I have a laryngospasm? Could I have a seizure? Yeah. You got to remember the signs and symptoms of hypocalcemia here. You're going to miss test questions. All right, everybody in here knows how hypothyroidism feels. Remember how you felt about 2:30 yesterday afternoon? That's what it feels like here, okay? Hypothyroidism, no energy myxedema is another word for it, okay? Now, when this is present at birth, it's called cretinism, which is very dangerous because this can lead to slowed and mental physical development if it's undetected. So, mother brings baby back for 6-week checkup. What does mother say to the physician that tells the doctor, uh-oh, we better order a thyroid profile on this baby? Ask your friend. Come on. Tell me, what does mama say about the baby? Yes, I have got the best baby in the whole wide world. You know that thing hadn't woke up since I brought her home. She has slept all night, every night. She's eating a little bit, gaining weight. Look how fat she is. Why, yes, the baby's fat because what's happened to the baby's metabolism? It's dropped out the bottom. So even if they're just taking a little bit of their formula, they're holding on to every calorie. Babies are supposed to wake up, aren't they? So when they're that good, thyroid profile. All right, now think adult here as we go through these symptoms. Fatigue, GI tract. Would you say it's going to be fast or slow? Slow. Your weight's going to start to go up. You know, anytime somebody's gained them 20 pounds, what's the first thing they say? I'm going to get my thyroid checked, right? Okay? We've all heard that. Is this patient hot or cold? Cold all the time. They want more blankets and they want the heat turned up in the room, but don't ever pick an answer like, here's a heating pad, okay? Because that could be a safety issue, couldn't it? They may not be able to tell when it's getting too hot. Speech may be slow or slurred. Y'all, it takes energy to articulate words. It takes muscles to articulate words. Have you ever been so tired after a test in clinical that you could barely talk to your friend on the phone? You know that feeling, okay? All right, that's what's happening here. And no expression. You're too tired to have any expression. It takes energy to have expression. You may be taking care of a totally immobile patient. Just like any other disease, there are degrees of hypothyroidism. You can have a little case of it where you've gained weight and you just feel yucky, but you're still able to go to work every day. And then you can have the extreme case where the patient is immobile. Now look at these symptoms with me. Gaining weight, no expression, I don't feel like doing anything. What psychiatric illness might this be confused with? Depression. Depression. Whereas hyperthyroid person that's wild with energy running up down the hall with exophthalmos looks like who? Manic. The manic patient. That's why in psychiatric hospitals, one of the first sets of lab work they do is a thyroid profile on everybody. just to make sure they aren't dealing with something physiologic instead of psychologic. Now, treatment for hypothyroidism. Next page. Synthroid, proloid, cytomel. Do they take these medicines forever? Yes, they have to take them forever and ever and ever. And what will happen to their energy level when they start taking these medicines? It should go up. What do you think is going to happen to their heart rate and blood pressure? Up. Now, look at this next sentence with me. People with hypothyroidism tend to have CAD. What do those letters stand for? Coronary artery disease. Coronary artery disease. And to be honest with you, they really don't know why. Okay? But we're going to accept that fact. Coronary artery disease. Okay, so what's the nursing implication here? Well, I'm giving my hypothyroid person Synthroid IV to get them built up. And now I know that they might have some coronary artery disease when I start, and I'm increasing the workload on the heart with this drug, aren't I? By increasing the blood pressure and increasing the heart rate. So what might my patient start complaining of? You start watching for chest pain and rhythm changes. Any kind of heart stuff here. When you're given this drug, you look for chest pain, rhythm changes, anything related to the heart. It's going to be a problem to us. Assume the worst. Y'all, now we got the parathyroids again. I am determined for you to understand the parathyroids, okay? Are the parathyroids the same as the thyroid? No. So why do you pick iodine every time you get a parathyroid question? Because it just looks good, doesn't it, okay? From this point forward, when you see the word parathyroid, you better think calcium. That's the first thing you need to think of is calcium. When you see a thyroid question, what dietary element should you be thinking of? Iodine first, unless I've had a thyroidectomy, and then you can think of calcium. Because of the thyroidectomy, they might take out a couple of your parathyroids. But iodine first, thyroidectomy, then I can think of hypocalcemia. But with parathyroid, I should never pick shrimp for an answer. Now, should I? No. The parathyroids secrete what? PTH, which makes you pull calcium from the bone and place it in the blood. Therefore, the serum calcium level just went up. If you have too much parathormone in your body, the serum calcium level will be very high. If you do not have any parathormone in your body, the serum calcium level will be low. Now, hyperparathyroidism is the exact same thing as hypercalcemia, which is the exact same thing as hypophosphatemia, because we know that calcium and phosphorus have what type of relationship? Inverse. All right, so here we go. Too much what? PTH. So your serum calcium is high and your serum phos is low. Treatment. One thing they may do is a partial parathyroidectomy. When you take out 2 of your parathyroids, PTH secretion should decrease, so my serum calcium should come down. That's the name of the game. I want my serum calcium to come down after this surgery. But since we're taking NCLEX and we're looking for life-threatening situations, what's the bad thing that could happen to my calcium? It bottoms out. That's the bad thing. It could bottom out, and now I'm having seizures and laryngeal spasm and that sort of thing. Now, look at height, and notice on your handout, I didn't even give you any signs and symptoms here. You already know the symptoms from yesterday. Calcium acts like a what? Sedative. That's all you got to think of, is sedated from head to toe, muscles. Now, look at the next thing. Hypoparathyroidism is the same thing as hypocalcemia, which is the same thing as hyperphosphatemia. So see if you and your friend can fill in the next 3 blanks. Not enough PTH. So the serum calcium is low and the serum phos is high. All right, now the treatment. We talked about hypocalcemia yesterday. And one of the things that we said we would do when you're low on calcium is give you some calcium IV. But we said the most important thing to remember about IV calcium is before you start giving it, you better make sure your patient's on a heart monitor. Because calcium IV can do bad things to people. What are the two bad things we said it could do? Decrease your rate and widen your QRS. Now, yesterday, we said that in textbooks, it would say a certain degree of QRS widening is appropriate. Do you remember me saying that yesterday? Would that be a nice thing to think on NCLEX? No, because when you start widening somebody's QRS, I don't care if it says it's normal in a book. What do we have to say for NCLEX? Don't give any more, because if it gets any wider, they could go all the way to asystole. You never want to widen somebody's QRS. But, you know, if you take ACLS, they'll teach you in the course that a certain degree, a third of the depth of the QRS is how much widening you should have. Do they really think a new nurse with 2 weeks of vast nursing knowledge is going to know the exact height of the QRS and know just how much it's okay to widen? No. They would rather you say as a brand new nurse, I don't like any widening of the QRS. Now, there was a drug that we said we could give here too when your phosphorus was too high, which it is here. Ampagel, good job. Ampagel is the drug. And we said it's going to bind phosphorus. And then I said when you bind phosphorus, that makes it invisible. So that if it's invisible, that just made my serum phos come down, which was tricky. But it made my serum calcium go up. Is that a good thing or a bad thing? It's a good thing here because we're hypocalcemic and we want the serum calcium to come up. Okay, let's take a break.